So, welcome again to this lecture about pharmacoepidemiology. And this is also one of the lectures where we're going to address study designs in pharmacoepidemiology. In this lecture, I will try as much as possible to stick to chapter 3, though you have specific lecture addressing the retrospective design, I mean by that the case control design, and also a special lecture addressing the prospective design, I mean the cohort design. What I will do here is I will give an overview of this chapter, so make sure that we cover the things that we haven't covered elsewhere. And also we will talk about specific designs, the nested case control and the case crossover designs that these are designs that you haven't probably have had the chance to discuss anywhere else. Like in the previous lectures, you will see that I have some slides that are hidden or deleted, therefore you're not responsible for. So we start off with an outline. So number one is overview of study designs. Number two is experimental and quasi-experimental designs. We covered this in also in last year in PHA 421. So that would be some sort of an overview or a review, I mean. Number three, in observational designs, case report, case series. You've seen this before. I will talk a little bit maybe about ecological design. Cross-sectional designs, you've seen them before. Case control, we have a specific lecture. Cohort, we have a specific lecture. And as I said, maybe this is where I will probably focus more on nested case control design, the case crossover designs, and finish up with case studies and meta-analysis. Okay, so number one, overview of study designs. Purpose of research is to identify the objective of research will help in selecting an appropriate study design, and that cannot be overstated. If you know exactly what you want, you will know what type of study design can help you. And that is true in pharmacoepidemiology, in sociology, in any kind of um, topic. In fact, sometimes it will help you if you are going to do qualitative versus quantitative research. A study usually has three general purposes: description, identification or exploration of association, and determination of a causal relationship. And over here in this table, the chapter kind of described the different types of study designs that may be used to serve any of the three types of purposes. So for description, you can use case studies, case series, prevalence studies, cross-sectional studies. For identification, exploration of association, you may use a quasi-experimental cohort studies, case control study, and cross-sectional studies, whereas for determination of causal relationship, you probably have to stick to randomized controlled trial or quasi-experiments. Principle of study design. It's the ability to make accurate conclusion is one of the most important consideration when designing study. Thus, the need for validity. And we have addressed this issue of what is internal validity and what is external validity. You probably are familiar with this. Again, this could serve as just a review of things that you are aware of. So, internal validity. One common way of conceptualizing internal validity is the degree to which any statement of the effects are actually the results of the exposure of interest and not any other inferable variable. And internal validity is that your study is actually protected from threats, internal threats, meaning that you really are able to detect the association between the exposure and the outcome. External validity can be thought as the extent to which the conclusion from a given study can be extended beyond the current sample and target population to the general population or to another setting. يعني generalizability of the results, how much the whatever you found out in the study can be taken to a wider population. طبعا you may have heard me saying that internal and external validity sometimes they go against one another, because the more you put constrictions on your study so that to control things around that may impact your internal validity, your results are not generalizable to a wider population. So there are threats to validity. Validity is threatened by systematic error or bias through inappropriate study design, subject sampling, data analysis. Threats to internal validity هن confounding bias, selection bias, information bias. Typically دايما البايس هن the big arms of bias هن هول الثلاثة. So selection bias has to do with how you went about selecting your sample. إذا كان في a special group that was overrepresented. If you missed a special group, then you have a selection bias. Information bias has to do with how you collected your information, how you observed, how you were able to get the data. And was the data obtained accurate or inaccurate? Did you make mistakes in the measurement? Did you make mistake in while observing? And confounding variable is when you have a variable that is impacting the relationship between your exposure and your outcome, and therefore you need to uh, address that association. Randomized clinical controlled trials or a randomized clinical trial حسب if it's clinical or not, typically designed to maximize internal validity, which can be at the expense of the external validity. So uh, I've mentioned that a minute ago. The epidemiological approach to research uses data outside of experimental setting, which can increase the potential external validity. And if you remember when we were talking about the need for pharmacoepidemiological studies, we talked the need that sometimes there are questions that you cannot address through experimental design in phase 1, 2, 3. Are good up to a certain extent, but once the medication, the drug is out in the market, there are things, there are questions, there are issues that cannot be addressed using experimental, and therefore you have to go to the observational designs. This is why RCT are useful in assessing drug efficacy, and other epidemiological study design are useful in assessing drug effectiveness. And by now you're familiar between the difference between what is efficacy and what is effectiveness. Reliability is the precision of an estimate, its consistency over time or cross-study object, or the extent to which the estimate is reproducible. Any measurement includes both systematic and random error. Effort should be done to reduce both. Reliability is affected by random error. Basically, here the author is talking about reliability, and we have discussed the issue of reliability and validity of measurement. I may make a video specifically about reliability and validity of measurements where I go in details about what are the different types of reliabilities, what are the different types of validities regarding a measurement, not regarding a study. And in terms of reliability بحكي على test retest, بحكي على internal consistency, Cranbrook alphas, and other things. And in terms of validity, I talk about the predictive validity of an instrument, criterion related validity. I have a specific lecture for that, and I will see if I will have a lecture for that. I mean a video. Okay, study design process involve both selecting the appropriate design for the research question and the development and implementation of procedures to ensure that valid conclusion can be made. So instruments or tools used to measure, method of data collection, sampling procedures, training of personnel, data management, all كلهم part of the process, making sure that your study is done the appropriate way. Valid conclusion require minimal bias, appropriate measured, and methods of analysis. Methods to minimize bias are classified according to time of implementation, either during study design or during data analysis. So the point is, you have to make sure that everything done in your study is done appropriately. And if the mechanism of data collection has to be done appropriately, which makes you spend a lot of time training your personnel. The sampling procedure has to be done well so that you get a large enough sample size, but also a sample that is representative of the target population. The way you're going to carry out your data analysis also has to be done appropriately so you don't make any mistakes in terms of the interpretation of the results. Um, and also to address possible confounding and biases, you can either do that through the data analysis approach or through the study design. And I believe that there is a specific chapter that addresses um, things that has to do with the validity of the design itself. Yani in other terms, what can you do to protect your design from potential threats? يمكن هذا chapter number 6. We go over mechanisms of data analysis, يعني stratification, يعني multivariate analysis, and things that can be done at the level of the design, مثلا matching, among other technique, randomizations, among other techniques. So when you come to chapter number 6, you'd have to remember that we're talking about mechanism in terms of how to protect the study from biases. A very important issue who are reporting guidelines. You probably remember the last time in PHA 421 we had you go over an RCT and we gave you the consort اللي هو consolidated standards of reporting trials guidelines, and you had like list of questions that you had to fill while reading the article. So by doing so you would be checking if all the elements required by this consort are addressed in the RCT in terms of actually reporting it. And this is true for other designs, case control, cohort, meta analysis حتى. All designs you can find online guidelines on how they're supposed to be reported. They can help you if you're actually writing a study, writing a manuscript. But if you're not at that level, if you're at the level where you are working with someone, I mean, if at the level where you're actually reviewing an article, reviewing a manuscript, you're reviewing a study, and you want to present it, if you want to know how good of a job the authors did, you can get the statement, اللي مثلا, for example, the consort, and go over it and see if the article is addressing all the details listed in these statements. So the consort is good for reporting trials, yani experimental designs, and you can find them on consortstatement.org. There are many others. I think Heidi's slide and the slide that comes after it are just the exact same thing. So this is a list of of statements out there that you can use whenever you're reading a specific article and you want to evaluate how good they did in the reporting. I'm not gonna go over them كلهم, but just for you to be familiar with some names. So في عنا شيء مثلا اسمه الستروب, so which is unique to various epidemiological study designs. So strobe is one of them that you will hear about when you start reading article and you want to evaluate them. Trend is good for non-randomized design, يعني مثلا for experimental design. IPSE guideline for good pharmacological practice, هو International Pharmacoepidemiological SP, I don't know what SP is. ISPOR كمان هي International Society for Pharmacoepidemiology, that's it. وفي الإسبور اللي هو International Society for Pharmacoeconomics and Outcome Research, they also have their good checklist for retrospective data studies. كمان they're very good. Other ones that you also need to be very familiar in البريزما والموس. البريزما is used for systematic reviews and meta-analysis, and you will hear about them a lot. And the MOOS is for meta-analysis of observational studies in epidemiology. لأنه meta-analysis is not only done for clinical trials, you can have meta-analysis of observational studies, and in that case you would use the MOOS statements. Okay, so for experimental and quasi-experimental designs, if you want to, you can go back to last year's lectures to review the things that we have mentioned last year. Everything we talked about last year still stands. So it's going to be a brief overview. So intervention and quasi-intervention designs are two designs that are mostly interventional, where researchers to a varying degree actively implement an intervention or treatment. هلا ليش to a varying degree؟ لأنه because of the concept of randomization. But anyway, observational studies are more frequently used by epidemiologists, not requiring any active manipulation. Elements of an experiment are three: the R, the C, and the T. هلا هون حاطين I، يعني randomization, control group, and the T or the I for intervention, يعني manipulation. So randomization is called random assignment or random allocation, not to be mistaken with random sampling. So you're not actually taking a sample. When you're randomizing, you're not taking a sample. When you're randomizing, you're putting your sample into 2 or 3 groups. It's the random allocation. Okay, not to be mistaken with random sampling. And basically, most of the time, you're randomly allocating your participants in either taking the placebo or the treatment itself. If you do not do it, then your study is quasi-experimental, and it will be called the non-equivalent control group. So like if you lose the control group بيصير عندكم شيء اسمه time series, also known as interrupted time series, involves repeated measures taken before and after the intervention, often used to evaluate the effect of a new program or a policy, such as change in formulary made to determine the impact on physician prescription behavior. Observation of the trend before and after allows to make conclusions. You have to make multiple observation before and multiple observation after, therefore the name time series. Example of time series: Chen et al. Examined monthly usage of antidepressants and antipsychotics for 12 months before and 12 months after the introduction of Medicare Part D. In their results, they found out that antidepressant before, the trend of slight increase, antidepressant after, much more prominent increase. For antipsychotic before the implementation of Medicare Part D, the trend was to decrease, and after there was a reverse in trend and it started going up. So this is the graphical display of interrupted time series. So design A is a standard interrupted time series. Basically, you have observation, 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 and then the intervention, which is shown as X when I'm doing intervention, and O for observation, and then you observe, observe. You have a design that adds to B, where you're still doing an interrupted time series, but you also have a control group. And finally, you have a deprived group or removal of intervention. So instead of actually adding something, you're removing something. But to me, really, A and C are exactly the same thing. Whenever you're doing something, whether you're adding or removing, it's still some sort of an intervention. So in interrupted time series, the intervention is typically a program or policy. We mentioned that. Useful when randomization is not feasible. Useful to evaluate how events affect an entire group of people simultaneously. مثلا الميديكير Part D. Advertising strategy newly implemented. Direct consumer advertising. And how to see one or two affect the use of drug. Bear in mind that X may be something under the control of the researcher or something that happened during not controlled by the researcher. مثلا in Lebanon and the unified prescription, which was implemented a few years ago, that was not under the control of the researchers, but still you could in principle um, uh, study the impact of this implementation. If you do not have a randomization, then it's the non-equivalent control group, and basically you have a control group but it's not randomized. This design occur typically in 2 situations. لما بيكون في self selection, individuals decide which arm they want to be part of. Automatic example here, we have the automatic refill program offered by a community pharmacy to improve adherence to medication. Patients decide themselves if they want to take part of it or not. I'll preform the groups: patients coming to a clinic, geographical area, using same insurance, and they're already preformed, and therefore you're not going to randomize them. Selection bias is the most important threat to this internal validity. You may ask yourself, if I'm letting them pick if they wanted the automatic refill ولا لا, هل يا ترى هن the ones that are actually a better group are being picking themselves to go into the intervention arm, and therefore the difference you're going to observe is not due to the intervention, rather than the fact that they are they themselves going into a specific group. Example of non-equivalent control group: Martin and Dell studied the effect of distribution guidelines on prescribing behavior in the Netherlands. The intervention group in a random sample of providers in Maastricht, while a control group random sample of providers outside the region. So it was much easier for them to look inside than outside. Another study, the author sent a letter about the appropriate use of dipyridamole to providers in the 3 sections of Wisconsin's, with the 3rd section serving as control. So, conclusion for quasi-experiment: the strength useful where pre-selection and randomization of groups is difficult, saves times and resources versus experimental design. They are reasonable alternative when randomization is not possible, and a certain policy has to be applied for everyone in the population. هلا we come to talk about observational design. So خلصنا experimental design. Observation design, general word. The observational study design have been used a lot in the biomedical research in situations where experimental or quasi-experimental design cannot be applied for reasons. مثلا it's unnecessary, it's unethical, or it's inappropriate. It is becoming more recognized that RCT may not be the best approach to examine pattern of drug use and drug use outcome. You remember, these are the big 2 outcomes in pharmacoepidemiology, especially for safety-related outcomes where pre-marketing studies lack the sample size to detect by common side effects. And we talked about this. We talked about why there is a need for post-marketing study design. We listed in, I think it was chapter 1, the need. One of them, sample may not be as large enough, and you might start seeing things that are rare that you could not see in experimental design. Among other reasons, you can go back and check them. Whereas observational studies are useful in studying the use of drug and their outcome, like unintended beneficial effect of drugs. Case report and case series, basically, these are, and you've seen this come in previously, but and I'm going over these things just to make sure that we are going over the entire material of the chapter. So case report describe clinical experience of one patient with a particular drug. أما case series, it's multiple patients. Okay. I think the most important thing to know here is that you cannot test a hypothesis in case report case series لأنه ما عندكم control group, but they're good in terms of rising a red flag. They're good in terms of generating a research question, a hypothesis. So these are descriptive studies used to generate hypotheses, not to test them. And usually they include adverse drug event reports, unidentified novel use of drugs, unintended beneficial effects for future investigation. So they don't include a control or randomization, so they cannot be used to make any causal determination, obviously. However, they are used to clarify previously determined causal relationship. They're good for raising red flags, as I said. Ecological studies, there's another word for them. I think they're also called correlation studies. In some situations, the data are available at the group level and not at the individual patient level, because obtaining patient level data is cost prohibitive. Our patient level data is not feasible based on the regulation of the surrounding healthcare data. It is done by gathering information in the aggregate. مثلا بدل ما نطلع على one individual at a time, we look at chain or community pharmacy. So we're not sure who's buying what, but we're showing that at this community level, the number of patients coming with this type, with heart disease is this much, and the number of medications sold is that much. From a group of health plans, so I know that مثلا GlobeMed and the هالقد patients, out of these patients, هالقد are diagnosed with certain common disease, and we know that they're covered this type of medication, and therefore they paid back patients this much for this type of, for these drugs. So you have aggregated data rather than individual data. The highest level of aggregation is at the country level. مثلا at the country level فينا نعمل per capita in this country how much meat is consumed, and per capita country how much antidepressant is utilized, and therefore you try to correlate between the per capita Obviously, you would have multiple countries and you try to see what is happening. However, your analysis is not at the level of the individual; it's the level of the aggregate, and you don't know if there is some sort of confounding happening, and if there is a confounding, you cannot control for it. So commonly used group data in pharmacoepidemiology in the drug usage at the national or state level, data on entire physician practices, our health plans, our hospitals are examined. The major drawback, presence of confounding resulting from not having data on the individual level, yet inter, interpreting the results at the level of the individual. This is called ecological fallacy. So ecological fallacy بتشوفوا an association that is at the level of an aggregate, but your interpretation is at the level of the individual. So كل ما علا income of a country, the cancer بيعلى. And therefore, you conclude that cancer is related to the socioeconomic status of the individual. That is ecological fallacy. Okay? كل ما import on tobacco rises in a certain country, so you're comparing 6, 7 countries and you're ranking them with regard to their import of tobacco, okay? And you're finding out that if you rank them highest to lowest, you also look at the death from heart disease, you find that it's also highest to lowest. And therefore, you conclude that there is a relationship between the two. So what you observe is at the aggregate level. However, your conclusion, you're saying, well, smokers have a high risk of dying from heart disease. This is ecological fallacy. There is another fallacy which I think is the atomistic fallacy, is when data collected at the individual level is used to make conclusion at the aggregate level. Yani the other way around. You figure out that the more people consume مثلا um, fat, the higher is their cholesterol. The higher the people that consume more fat loses, they take more off at work, and therefore you conclude that at the national level, countries that have a higher level of consumption of fat and the countries that have the highest level of employer sickness, and that might not also hold to be true, and therefore you be committing an atomistic fallacy. Typically, the unit of analysis is used for both exposure and outcome. State level data for prescription is used, and the state level data should be used for outcome. Except that the multivariate modeling technique allow the incorporation of both aggregate and patient level data. So that takes us to cross-sectional studies. Cross-sectional studies, لأنهم prospective ولأنهم retrospective. This is where you're looking at the exposure and the outcome at the same time. So looking at sample of specific population of a specific time, the outcome and exposure of interest are determined simultaneously. This is single point for data collection. Provide estimates of prevalence. They're very good for prevalence of a condition or exposure, but do not estimate the incidence, and also called the prevalence study. So cross-sectional studies and in the prevalence studies. Basically, you get a very good idea of what is the prevalence, but it doesn't tell you anything about the incidence, and by now you know the difference between prevalence and incidence. An example is by Stang et al. They study with primary objective to describe the prevalence of the co-prescription of contraindicated drugs with statins. So they were interested in prevalence, therefore you would do a cross-sectional study. You have probably seen this before, like this is how one author represents the cross-section studies. Squares are the exposure status of the individual. So a dark squares, yeah. Dark square معناتها exposed, a light square معناتها unexposed, and a dark circle معناتها the outcome occurred, and a white circle which you won't see because it's actually transparent means the outcome did not occur. So you come at one point in time, you take the sample not knowing their status, then you split them into exposed and not exposed, and then you look at how many had the outcome, yani the prevalence in the exposed and the prevalence in the not exposed. طبعا you cannot talk about causation, you only talk about association. And you can actually do series cross-sectional to see what is happening over time This is typically done مثلا if you want to know about the prevalence of smoking among teenagers over time. So maybe every 1 or 2 years you do cross-section study and you look at the prevalence of teenage smoking year after year after year after year, and it will give you an idea of how the prevalence of teen smoking is changing over time. So multiple cross-sectional studies. The example is Lieberman and al. Studied the use of a number of drugs in children and adolescents. Data came from large pharmacy benefits management firm, and the prevalence was assessed monthly from September 2004 to June 2007. It's useful to examine changes in prevalence in time, can be used to approximate data from longitudinal study. Data collection and data source are critical for accuracy of results. By the way, if you Google مثلا smoking prevalence, you will notice that in the 60s كان smoking prevalence عم يعلى among the population, then it plateaued, and over the maybe the past 20 years, it has been dropping. Wholly, they're done through serial cross-sectional studies. Every year بيصير في some sort of a survey of everybody, and they look about how many of them are smoking. And it could be like a medication, it could be any kind of exposure. True longitudinal studies مثل cohort are stronger than multiple cross-sectional study because multiple measurement of same subject over. منشان هيك we talk about within subject effect. Within subject, and you have the same subject and you're measuring that subject again and again and again, which we do not have in serial cross-sectional because they're not the same people. يعني مثلا you might be interested in knowing what is happening at LAU in terms of, let's say, how well our students are doing on a general test about public health information. If every year we do a test for LAU students, year after year after year after year, to see what is happening to them, obviously after 3 years, maybe the entire people would change. I mean, have another cohort of students getting in and out of the university. So you would not be studying the same people, and you don't want to actually. So the cohort, the longitudinal, is better because you're measuring the same person, and every subject can serve as their own control. The exposure known to occur before the outcome offer the ability to look at change within the subject unit and across the units, and changes can be separated from the individual baseline characteristics. That takes us to the case control studies, which I will not cover here because we have a specific lecture for that. So I'm skipping these slides. I'm skipping. You probably have seen them. Then the next on the list is cohort studies come in. I will not cover them. They're available on a different presentation. So I'm just gonna go all the way till I reach something called the nested case control design. So what is a nested case control design? It's a case control study that is nested inside a cohort. Actually, it could be nested حتى inside an RCT. But anyway, a case control study is nested when it occurs within a defined cohort. In a nested case control study, the cases are all from the cases of the outcome of interest that occur within a defined cohort. Let me read and maybe I'll explain later. Most of the nested, they use something called the risk set sampling or the density sampling for controls. Yani the controls are selected from among the cohort member who are still alive and who have not been diagnosed with the outcome of interest as of the date of onset of the respective cases, meaning they are still at risk of the outcome. It also means that the control will have approximately the same amount of follow-up years than the cases. In a case control study, individuals selected as controls at one point in time can become cases subsequently. So I'm gonna just read the slides and I'll try to explain that. So HIDA risk set sampling. Maybe this is an open cohort. You have individual coming in and being followed over time. Some are followed more than others, which is typical in an open cohort. Not everybody is recruited at the same time. مثل RCT, كمان not everybody is recruited at the same time. And the follow-up period changes from individual to individual. So what happened is in a nested case control, you're going to take all the cases. يعني كل يلي صار معه الoutcome, you're going to take them and you're going to consider them as your cases. So though the design originally was a prospective design, when you come to actually do the nested case control, your approach is going to resemble the approach of a case control. So you go and you search those that got the outcome. And once you find one with an outcome, you need to find a control for them. So let's say the first person that had the outcome is this person right there. For that person, you need to find a control that will serve as a control. And as you know, in a case control design, the control is someone who does not have the outcome. So you need to find from among those that are available when the outcome occurred. So ملنقول the time هو this study started بال2000. This is your starting point, and 2020 is where everything ended, or maybe it's still going on. Okay, so we have 20 years follow-up. As you can see, some of them the follow-up started right at the year 2000, and some people the follow-up started at later on. So maybe this individual was started following that individual in 2001, and in 2005 they had the outcome. So that person was identified as a case in 2005. You look for all those that you have in 2005 that did not have the outcome. So a couple of things to notice. Some people you have not started to follow up until this individual here in 2005, and therefore that individual will not be part of the potential controls, okay, because they were not selected. We don't have an example of maybe someone you started follow up and then they stopped being follow up. Come in, that individual will not be part of your control. So only those that were part of the follow up in 2005 would be potential for being selected for control, even though some of them, like this individual here, and this individual there, and this individual right there, even if some of them actually became cases at a later point in time. What matters is that in 2005, they did not have the outcome. Okay? And therefore, you select a control for that individual. And therefore, you're going to go from case to case, and for every case you're going to follow up the same procedure. So for example, right here, when you come to select this case right there, let's say this case occurred in 2017, you're going to look for all those potential controls in 2017, and those that are potentially available هن مثلا this, that, all of those, this one, but whole كلهم are not available. This is not available, this one is available, this one is available, but then everything else is not available. Okay, so this is how you actually go about selecting your cases and your controls from a cohort. So you're selecting based on the outcome. Like any type of case control, your selection is based on the outcome. So you select those with the outcome and those without the outcome. The controls have approximately the same person time contribution as the cases. Um, so you probably remember Shumaneta person years, so it's the amount of years contributed per person. So the cases and the controls kind of have the same amount of person years, kind of. The nested case control, smaller sample can be used than the entire cohort. This is helpful and makes sense and is economical when logistical and or cost consideration make it difficult or impossible to measure / a certain exposure status in the entire cohort. And probably this is the most important aspect of about the nested. I will explain it, but let me finish the slide. If all relevant exposure information is available for everyone in a cohort, it is more sensible to use all of the data and conduct a cohort analysis. Okay, so what we're saying is if a certain amount of exposure, remember it's not about the outcome because you have to assert an outcome to do a case control. Okay, you're going to take probably all the cases but not all the controls. So how are you saving by taking not all the controls, part of the controls? You're saving on measuring the exposure. Usually, this exposure is something that is expensive to measure. Yani, let's say, for example, it could be a a blood that you have collected in your cohort أو in this RCT, and it could be maybe a gene defect. However, you measuring if this gene defect is present or not costs a lot of money. So you decide that you're going to get a bunch of people, maybe 5,000 or 6,000 people, and you're going to follow them up, not knowing if they have the gene effect wala la. And as the follow-up over 20 years ends, you may have out of the 6,000 masalan 85 individuals that had the outcome. So you get these 85 whole your cases, you get their blood samples which was selected, which was taken back in year 2000 or the year where they started being part of your study. You take the blood sample that has been frozen, you send it to the lab to be analyzed. So you're only analyzing 85 blood samples. Now, out of you're going to also take controls. But instead of taking the 5,900 something as your controls, you're going to say لا هياخد مثلا one control per case. And therefore you end up with 85 controls only. And those 85 controls, you already have their blood sample frozen. You will send it to the lab to be tested. And you end up figuring out if they were exposed or not based on their blood samples. But you would not run the blood samples for everybody, saving on money. Okay, so that's the idea. Sometimes what happened is you have an RCT or a cohort that is running, and this RCT part of the protocols collected the blood مثلا to look at let's say triglycerides or maybe cholesterol or what have you. And the study is running and has been running for 20 years. And then something came up in the literature linking your outcome. Maybe you were interested in a problem in the kidney failure. And something came in the literature saying that in fact kidney failure is associated with a certain presence of a gene. And you realize that you are assessing kidney failure. So in this case, in this cohort, you have cases that developed kidney failure, and you have their blood sample selected in the past, but you never sent it to be measured for this gene. And therefore, you decide that you know what, I'm going to capitalize on the fact that I have this cohort, and I'm going to run a nested case control inside this cohort to see and able to answer that research question. Okay, I hope this explains a little bit Shumanita and nested case control. So it's a case control study done the way a case control study, meaning you start with the outcome and no outcome, and you evaluate the exposure afterwards. However, this is done within an RCT or within a cohort, and maybe towards the end of the lecture, I will share with you an example from the literature. The other design that you probably haven't seen is the case crossover studies. كنت تنتبهوا قد ايه في كلمة studies with case. So عندكم case report, case series, case control, and case crossover studies. Okay, nested case control. So كل واحدة منهم is a different design. وحتى case crossover is also problematic, not only because it has case, but also it has crossover. And you probably remember that part of the experimental design في شيء اسمه crossover design, where you have treatment and placebo, and then you flip them. Those that were on placebo start taking the treatment, and those taking the treatment start taking the placebo. هذه كان اسمها the crossover design. This is called the case crossover design. Okay, and let's talk about it. It's analog to the randomized crossover design in experimental research. So it's analog, and you're going to flip, but you're not actually flipping an entire group. What is happening is this: each participant experiences a period of exposure. So here's the key term: it's period, and a period of non-exposure, whereby the outcome of interest is measured following each period. Okay, so like as a person, you're going through periods of exposed and not exposed. That exposure could be, for example, a period of time where somebody might be مثلا doing excessive very demanding exercise. So طالما هو عم يعمل demanding very demanding exercise, he's exposed. And then مثلا for 3 days he's not doing any exercising. Okay, so individuals, people go through periods day after day of exposure and not exposure, and therefore every person serves as their own control, meaning that everybody in the case crossover studies are cases. So this is a study where everybody is a case. And the way you're going to have control is that you're going to ask whether the outcome occurred within a period where that person was exposed, while within a period when that person was not exposed. So let me show you the graph and hoping that it will make things clearer. So before I do that, each subject serves as his or her self-matched control, therefore eliminating confounding factor. Okay, so the, the way we're going to look at this is we're going to start with A, and in A you have 4 individuals, and the follow-up is from January, February, March, April, يعني January 1 to April 30, and you have the exact date when these people actually had their outcome اللي هو related to heart. So this is the first slide. The second slide, we're going to superimpose on this graph periods in pink, and these periods in pink where they were exposed to air pollution. Okay, so كان في period of time where there was no air pollution in the city مثلا, and there was period of time where air pollution in the city was very very high, so everybody is exposed to the air pollution. وبدنا نعرف, does air pollution play a role in people having the heart outcome? Okay, and therefore what's going to happen is you're going to go to C. So not only now we know where the outcome occurred and the period of if the period was actually exposure period يعني pink ولا non-exposure يعني white, but we also have a preceding period, maybe few days or couple of weeks before the outcome, and this is going to be considered the at-risk period. And so basically what happened, as I was saying, every outcome just before the period of time that the outcome happened, like 2 weeks before the period where the outcome happened, is considered the period at risk, and exposure, or maybe like the case, maybe. So for example, the first person during their risk period, there was no pollution. The other 3 can feel pollution. Okay, but that is not enough. You have to have a control period as well. So you go back maybe like a month, if I'm not mistaken. Yes, I think it's a month. So from here where it happened, 2 weeks to reach this, and then you have another 2 weeks, right? So you go 1 month, and then you take the 2 weeks preceding, and that would be your control period. And therefore this person مثلا, their risk period can't empty and their control period can't empty. This person, their risk period can exposed and their control was not exposed. This person come in, their risk period they were exposed, their control were not exposed, whereas this person both the risk and the controlled were exposed, and therefore you end up with a combination, and you can try and see like is like more of these scenarios, the 2 and the 3 happening versus the 1 and 4. 1 and 4 are probably indicating that the time period of exposure did not impact the occurrence of the outcome. Okay, because nothing, I mean, you can see what happened. Whereas here, you can see that more of this means that the pollution is related to the outcome. So if case control are set to answer the question why me, the case crossover are set to answer the question why now. The case component of the hazard period is time before the disease or event onset, whereas the control component is the control period, time over than the hazard period. Okay, so and you have examples. The chapter then finishes with meta-analysis, but I won't cover it in this video. I mean, you have the slides, you can read them. They're simple, they're straightforward. Thank you for watching.